These types of fractures are best seen on CT, all right? So even though in this series, we're not concentrating that much on CTs, this is what the CT scan looks like. Okay, so here's where you can actually see the C1, right? You can see how it's moved away from C2. And here you can actually see the fractures that have taken place, all right? So that's the reason why it starts to split apart. Okay. Like I say, anytime you've got a ring structure, it's very difficult to break it in one place, you know? It often breaks in more than one place. Now, we don't stress, we're gonna just follow. So first thing that we do is first, let's see if it's an adequate X-ray, all right? So can we see all the parts that we need to? So we see C1, C2, C3, C4, C5, C6, C7. So we can see it, all right? Now let's follow these lines, okay? So we're gonna follow this anterior line. And what do you notice? What's happening there? Can you see how it just jumps a little bit? Right, okay. And then when you follow the middle line, when you come here, you can see it does that, all right? Okay, so you can see it's out of alignment, all right? And then when you follow the last one, you can also see it just jumps out of alignment over there. So would you be worried about this patient? Sure, because there's a few things. Number one, the spine is not curved the way it normally should be. So your spine should normally curve like that, but instead you've got an absolutely straight spine because of muscle spasm. So your body's trying to protect the C-spine by itself, but you've also got this movement out. So would you put this patient in a neck collar? Yes. Would you do a CT scan? Yes. Now this particular one is called a hangman's fracture. We had seen it before in one of the previous ones. I was just showing it to the guy. I was just planning to show it again. So here you can see how it's moved out of place, all right? And you can see this is quite a serious injury. I mean, if you look at this patient is intubated, this patient has multiple probes on them, things like that. So this patient was obviously quite sick, right? And then this is what it looks like on a CT scan, right? So what they're saying is that it actually extends through the C2 completely, all right? But that's what it looks like on CT, okay? All right. So this is an odontoid peg fracture, right? Can you see that fracture that's running over there? So this is C1, this is C2 on a CT scan, and then this is what the odontoid peg fracture looks like, right? So there's a few types of fractures of the odontoid pegs. Mainly there's mainly two types, all right? So type 1 occurs at the tip of the process, all right? And type 2 occurs at the base, all right? And type 3 occurs through the, through the vertebral body as well. Now, these are not so important to remember and jot down. Don't stress about it, all right? But the thing is, whenever you have these, if you have a fracture just through the tip, that's generally regarded as stable. But once you have one through the base or through the body, they're essentially considered unstable fractures. But in our case, what we would do anytime we suspected an odontoid fracture, we would do a CT scan, and then we would refer the patient to orthopedics, or then refer to a spinal unit, all right? So type 1 is not as common, all right? But type 2 do tend to happen, and that's basically what they're talking about here, all right? Okay. All right. So here we have a look at what odontoid peg fractures look like. So it's a bit hard to see on these, but here you can see a bit of a fracture along the odontoid peg at the bottom. And this is what it looks like on CT scan. It's sometimes very difficult to see it on the lateral view. The main thing you can see on the lateral view is actually the straightness of the neck and things like that. But sometimes you can pick up a little fracture, but the best way to pick it up is on an open mouth view. Okay. All right. Okay. So this is again odontoid fractures, all right? So this is where you see the anterior angulation of the dents, which basically means if you were to look at C2, you could actually see this thing moving forward, all right? It's supposed to be straight. It's recording again. Okay. All right, and then, thank you. All right. So these are just showing the fractures that can go, as you can see, it extends into the body as well, all right? So it's not just the base of the odontoid or the tip, it actually extends into the vertebral body, all right? So those are just the three types that you get, okay, of odontoid fractures. So this is atlantoaxial dislocation, right? Which basically means the atlas and the axis, C1 and C2 have dislocated from one another, all right? So what happens in this one? If you were to follow your lines, you would see that C1 is actually quite far ahead of where C2 is, all right? There's C2 and there's C1. If you were to follow your posterior line, you would see how far C1 is ahead, all right? So that's what happens when C1 basically is completely dislocated from C2, okay? So it can happen normally on flexion, but it's not that common, all right? So what happens is you get swelling of the neck, you get the severe pain, things like that. And these patients have to be reviewed by a spinal unit, okay? I'm just trying to get through this thing before it cuts off again, that's all right. And then you get what they call atlanto-occipital dislocation. So in other words, C1 is dislocated from the rest of the skull. So basically, an internal decapitation, right? So the skull is not connected to the spine, okay? Now, these are probably the hardest ones to pick up on X-ray, okay? They do happen, but they're extremely difficult to pick up. The main thing that would be picked up, if we were to look, for example, at, let's look at this. Can you see the airway here? All right. The airway is quite close to the spine, actually. And then when you go to this one, you see how far away it's moved, because this is swelling, severe soft tissue swelling. All right. So this is what they mean by prevertebral soft tissue swelling. It's the most, how can I put it, common sign that you would see in terms of an atlanto-occipital dislocation. Right? So these ones here, when they do happen, they're of course unstable because the skull is just riding around on top of a C-spine that's not connected to it. So your patient has a high possibility of paralysis. Okay, so let's just see. So this is what it looks like on CT scan, right? Or no, this is what they call it, other type of scan. No, not MRI. There's the other one. It's the quick. It's a load scan or something they call it. Right? Anyway, whatever it is. So basically, what happens is that all the ligaments that normally connected to just basically are damaged and pulled through. All right. Sometimes you can only see it on MRI. Sometimes you can see it on CT. It just depends. All right. So the main problem with these ones is that they have a secondary injury to the brainstem. So once you injure the brainstem, then you have cardio and respiratory basically decrease. So cardiac, bradycardia, bradypnea, and then eventually cardiac arrest and respiratory arrest. All right. So they result from hyperextension, distraction, rotary forces. They're highly unstable. It has to be fixed. And the problem is with these ones, just a cervical collar is not enough. So these are normally the patients who have halos and things like that, those things that you see with the spines. These are the ones that normally have them. All right. And then you can have a lot of other injuries that are normally associated with this. Okay. It's twice as common in children, right, due to their immature joints. Right. You can just leave that on. Right. Okay. And it also occurs in Down syndrome and rheumatoid arthritis. Okay. So just something to think about. Okay. So this is just the, this is just the neuro distribution of the C-spine, right, in case you forgot. So that's where C2 normally distributes, C3, C4, C5, C6, C7, C8, and then T1, all right, and then the posterior view. So this is something nice to put into your brain, all right, and learn, okay, because then it helps you. As you're testing each dermatome, you can more or less determine where the patient has a deficiency or a deficit, and especially if you see there's deficiencies below C4, then you know, okay, I've got a problem at C4, so that's basically what we use it for, okay? And then of course you need to know the posterior ones as well so that you can work it out, okay? So yeah, that basically covers C-spine. Now we've done it over 3. This is the end of it, okay? That's just a little joke to finish off. So, okay, I thought, yeah, all right, yeah. Glad you'll enjoy that. Anyway, yeah, no problem. All right. So listen, what I would suggest is you guys go back, have a look at the previous ones that were there. And then this one here was just like a final one, just to look at some other weird cases that you sometimes see, all right? And then if you have any questions, you're more than welcome to let me know. But we're going to stop this one now, all right? And take it further. All right. So you guys have a good time in